Thank you for having me. As Charlotte was saying, that I'm a senior research associate in the Department of Public Health and Primary Care, also a fellow with the British Heart Foundation Centre for Research Excellence here at Cambridge. And today I'm going to be talking about enhancing cardiovascular risk prediction using polygenic risk scores and metabolic biomarkers. And clicker works, excellent. So risk scores for cardiovascular disease within 10 years have been around in some form in the clinic for almost 50 years now. And as a whole, they generally center around a common set of risk factors that include age, sex, whether a person smokes, has diabetes, what their lipid levels are, and what their blood pressure is. And over the years, there's been more and more scores that have been developed in different regions of the world. And today there's a few commonly used ones, and the one I'm going to be talking to you a lot about today is Score 2, which is recommended for use in Europe and is something that's the Department of Public Health and Primary Care has been instrumental in helping develop. So people like Stephen Kaptoge, who's in the audience, Lisa Pennells, and Emanuele Angelo Antonio were involved in leading the development of Score 2 and also developing extensions for high-risk groups like people with diabetes and people with older in elderly patient groups. And so what I've been working on for the last couple of years is looking at what the value of various new molecular assays is for helping improve risk prediction for cardiovascular disease within 10 years. And the main area that I've been interested in is primary prevention of CVD. So this is just showing you the European Society for Cardiology guidelines within Europe, which use Score 2. So Score 2 is somewhat unique in that it also uses the geographic region of Europe a person is having their risk evaluated in as a way of determining what absolute risk they're at. And the reason I'm interested in primary prevention rather than more specific patient groups is that if you take any person who's not diabetic, isn't particularly old, who has a CVD event, you'll find that a substantial fraction of these, depending on the risk score and risk threshold, between 40 and 86% of them, if you go back 10 years in the past, you'll see that they would have been evaluated as low risk with the recommended clinical risk score. So for a really long time now, clinical guidelines have recognized that there's a need to improve CVD risk prediction with additional risk factors. And one of the things that's been particularly promising recently is polygenic risk scores, which capture people's genetics beyond family history. But there's also been a long-standing interest in biomarkers as well for extending risk prediction. So we and others have shown in the past that polygenic risk scores can substantially add value and improve clinical risk prediction. And various cardiology bodies around the world have put out position statements in the last few years about how polygenic risk scores might be used in the clinic or how they can be integrated, partly due to this evidence and partly due to a large number of people coming in with genetic risk scores and saying, well, how does this relate to my cardiovascular risk? But the story with biomarkers has been a little bit less clear. So historically, there hasn't really been a whole lot of added value when people have looked at individual biomarkers of interest, so CRP being the sort of most notorious one people have looked at. But recently, there's been an emerging interest in aggregating lots of biomarkers together into biomarker scores. So with the emergence and development of sort of mature technologies for measuring lots of biomarkers at once from a single sample, people have started looking at this, showing that there are improvements in risk prediction. But people, when they evaluate risk prediction, they tend not to look at risk stratification. So allocating people into low versus high risk groups, which is how you actually would use a risk score in the clinic. So this is what we set out to do using data from UK Biobank. So for anyone who's not familiar, in the last few years, UK Biobank has published data from sort of lipidomics and metabolic biomarkers from nuclear mass, I want to say mass spectrometry, is not, it's nuclear magnetic resonance is the platform. And these are enriched for biomarkers that are relevant to CVD, where there's been a huge amount of evidence gathered over the last few decades about the CVD associations of these biomarkers, which is partly why this technology has been measured in UK Biobank. So we developed these metabolic biomarker scores in UK Biobank. So we used a subset of the data where the biomarker data has been published already. So 170,000 participants who are eligible for screening for first onset CVD. And then we also have, through various collaborations, advanced access to the rest of the metabolomics data that will be, theoretically, it should have been published last year by UK Biobank, but I think they've been having trouble with the RAP. So it's expected to come out sometime this year, I think. So we built biomarker scores for males and females separately. So males and females have very different cardiovascular risk profiles, and many risk scores treat the risk factors differently. And we also developed them for coronary heart disease and stroke separately, because CVD as an endpoint is very heterogeneous. And what we found when working with polygenic risk scores is that actually training new models to predict the individual endpoints tends to work a lot better than trying to predict CVD as a whole. And so when we do this, we actually see across the whole distribution of risk. So look, this is looking at so the change in C-index over score 2 alone, that adding these metabolic biomarker scores improves risk prediction about as much as polygenic risk scores. We also here looked at a sort of amalgamation of various different clinical biochemistry biomarkers that are available in UK Biobank. These are sort of very well-established clinical biomarkers. They do a little bit better, but with the added complexity of if you did want to use that in a clinical setting one day, you've got to essentially order multiple different assays, so it gets a little bit more complicated. And the information from biomarkers and polygenic risk scores is essentially orthogonal, so you can add them both together and get an even greater bump in your improvement in risk prediction. So that works out to be roughly a 10% improvement in the C-index over the whole distribution of risk. Reassuringly, when we go into the replication cohort, we see almost identical changes in C-index relative to score 2 alone. But of course, as I said earlier, we're not necessarily interested in the whole distribution of absolute risk. Being able to better predict whether someone's at 40 or 50% risk isn't that interesting when your risk threshold for treatment might be 10%. So we also looked at improvements in risk stratification. So following the ESC guidelines, using their risk thresholds, which are age dependent. Basically, if you're below 50 years and you have more than 7.5% risk, they recommend treating with statins. If you're over 50, your risk threshold is a little bit higher. And actually, when we start partitioning people into those low versus high risk buckets, we see that actually the information from biomarkers is about double that from what we see for polygenic risk scores, which is really encouraging. So, polygenic risk is sort of capturing what's baked in from conception, and then biomarkers are capturing the more dynamic aspect of risk that reflects, what's going on in a person's life, that is then going on to influence their disease risk. So again, reassuringly, we saw very similar numbers when we looked in the replication cohort. And then we wanted to ask the question of what might this look like if we were hypothetically to change screening practices to use these alternative models where score 2 has been extended. So as we all know, UK Biobank is not representative of the UK population. It's older and healthier. So you can see here the demographic distribution of age and sex for UK Biobank per 100,000 versus the mid-2023 population estimates from the Office for National Statistics. You can see that UK Biobank skews a bit older and a little bit more female. And actually, if you look at the CVD incidence rates in primary care patients who are CVD and statin-free, you can see that there's as expected, there's this huge difference between UK Biobank and the CVD incidence rates you'd expect in the more general population. So we took these risk stratifications of cases and non-cases into different buckets of low, medium, high risk, and basically standardized their allocations to the demographics of the UK to get a more representative idea of what this might look like if we were to screen with these counterfactual risk scores that have been extended. What we see is what you might expect. So per 100,000 people, you'd expect there to be about 6,500 incident CVDs within 10 years. Using score 2 alone, you get 4,500 people identified as high risk, including 1,000 of those future CVD events. And then when you start adding polygenic risk scores and metabolomics biomarkers, you see more people are allocated to the high risk group. More of the CVDs that you expect to happen are allocated to that high risk group as well, and you get a corresponding reduction in number needed to screen. We also wanted to look at what this might do to treatment. So one of the things I forgot to mention on the previous slides with net reclassification is that we saw a little bit of an inappropriate reclassification of non-cases into higher risk groups. So one of the things with this type of modeling is that it's very easy to see improvements in number needed to screen or the number of people allocated to high risk. So actually in the best case scenario, if you want to optimize for number needed to screen, you just put everyone in the high risk group, give everyone a statin, don't screen at all, and then your number needed to screen is 0. But then of course you end up prescribing so many more statins than you actually need. So here what we looked at is how many statins are prescribed per event prevented. And reassuringly, even though there was a little bit of inappropriate net reclassification for non-cases, the number needed to treat didn't really change at all with using these more powerful models, which is really encouraging to see. We also looked at a more targeted approach. So just taking the people who would have been classified as medium risk by score 2 and following them up with rescreening with these extended models. And as you might expect, you get a little bit higher numbers of people allocated to high risk, number of cases caught in that high risk group, but a little bit of a bump in the number of statins prescribed per event prevented. So an overall summary of what we've seen is that biomarkers compared to polygenic risk scores are something that we should think about taking seriously in the future for enhancing clinical risk scores for CVD prediction. Over the whole distribution of risk, they improve prediction about as much as polygenic risk scores, but looking at clinically relevant thresholds, they almost double that risk prediction. You could look at either these sort of multi-biomarker panels like NMR, where you can measure hundreds of biomarkers at once, or you can consider the more conventional clinical assays, but at an increased complexity of, you're having to order multiple different assay types to get a little bit stronger prediction. And the potential impact on screening is, if this is developed appropriately in the future, is that it could increase the number of CVD cases that would be treated with statins by 7% or up to 12% with targeted rescreening. But of course, there are multiple challenges for validating clinical utility and the details of potential implementation in the future. So a lot of people have been involved in this work. We've got a very old now preprint out, which just has some of the discovery analyses in it. The replication analysis is all new as of a couple of weeks ago. So hopefully this will be coming out or back in review soon and out later this year.